So our first speaker, Matthew McKay, after leaving the Royal Australian Air Force in 2002, he spent 8 years in Saudi Arabia as a contractor teaching the Royal Saudi Air Force flying pilots and weapons systems operators. On return to Australia, he worked for the Civil Aviation Safety Authority as a manager before joining Check 6 in 2015. Check 6 specialises in providing coaching and human factors training to offshore oil and gas personnel. So we welcome Matt.
Well, thanks very much, Mel, and thanks, folks, for joining us here this morning. I should point out I'm not actually Matt. Matt's sitting down here. My name's Mark Connelly. Matt and I are colleagues and both involved with the company Check 6, as Mel has introduced us. And as Mel said, what I'm here to do today is to talk to you about human factors. Sorry, excuse me, I'm just going to get myself organised before I start. So what we mean by the term human factors, and if I use that term, is that something that resonates with people? Is that something that you're used to hearing, or is that perhaps in terms of a psychology concept? We're talking about human factors operationally, and what it means is understanding the human being in the system of whatever it is that you're trying to do, in our experience, aviation, the capabilities and the limitations of the human beings bringing about the effect of your system, and what that means in terms of individuals and the way that they interrelate, communicate and work together. So my background, just very briefly, I am a pilot as well. I started out in the Air Force, the same as Matt, and had 16 years there, mainly flying multi-crew transport aeroplanes. And after that, I spent 8 years with the Royal Flying Doctor Service at their Bundaberg base, which was an interesting role. No doctors, so we were actually the Royal Flying Nursing Service out of Bundy, one pilot and one nurse doing predominantly inter-hospital transfer work. And when required, we would go and collect a retrieval team from Brisbane and take them to a particular case. After that, I spent a couple of years in Papua New Guinea flying regional airline operations up there, and now work for Check 6, basically applying my experience in aviation to sort of helping other professions and industries to try to improve performance and outcomes. So, which brings me to, is everybody here a member of APNA, or predominantly? Yeah, so I've looked at what it is that you're about, and I'm quite taken actually with your mission statement. Sometimes mission statements can tend to make people's eyes glaze over a bit, but I quite like yours. To improve the health of Australians through the delivery of quality evidence-based care by a bold and vibrant primary healthcare nursing workforce. So I'll take that as a starting point of what it is that as a group, collectively, we're trying to do. And that's quite simple. We want to deliver better healthcare for Australians by using quality best practice procedures. And there's a couple of visionary terms in there, by being a bold and vibrant workforce, which sort of calls, I suppose, the group to go above and beyond the everyday and look to do things in the best ways possible. So that's what, as a group, the members of the APNA are trying to do, and I'll expand it out a little bit to healthcare provision generally. And I understand that healthcare is actually a conglomerate of many different professions, but will you forgive me if I just refer to the healthcare profession overall. What health providers are trying to do collectively is obviously to take care of people like us when we fall over at soccer and tear a ligament or whatever it is that we do. We're dependent upon your expertise, your experience and your dedication to look after the most important thing for the rest of us, which is our health and that of our loved ones. What are some of the things that stand in the way of that mission for you as a group? What are some of the things that frustrate you or are the sort of the grind in the gears and the losses to heat and friction as that human system of delivering healthcare to us unfolds? And I guess I have a bit of an insight, having spent 8 years flying a plane while one of my best friends was stressing out 2 metres behind me, contending with those challenges. The sorts of things I've observed are resources, funding. There's never enough people. There's never the most modern piece of equipment that we would like to have that could actually do this better, if only they'd buy it for us. There's always that struggle to get to better resources, better diagnostic tools, better equipment. And potentially there are things that on a day-to-day basis you may look at and say, if only we were better resourced, we could actually solve that problem altogether. But as it is, we just have to live with it. Maybe, maybe not, but that's one of the things I've observed. Another key issue is simply time. When you're dealing with a human being with a health problem, sometimes you just have to make the best decision you can make based on the information that you have. You don't have the luxury of sitting back and blueprinting perfection. You just got to try something and see how it goes. Folded into that, a third issue, I suppose, would be complexity. I believe the World Health Organization lists something like 12,000 different afflictions and disorders that can affect the human body, and that's if they were polite enough to do it one at a time, but of course they will interact and there's comorbidities and makes it a vastly more complex sort of situation. And as a result of all of those things, I suppose there's stress and the impact that that has on the individuals who can only do so much to contend with all of that at once and still deliver the best outcomes. Is that a reasonable sort of summation of the problems that you face on a daily basis in trying to carry out the mission statement that we identified? Yep, sound. All right, thanks. So I guess the next thing I'd like to do is just consider what's the impact of those obstacles to your mission. And there's a lot of different ways that you can try to measure that. But generally, what we try to do from our aviation background is to take something of an engineering approach and try to define the problem, come up with a way to measure it and baseline it. And what I'd like to do next is talk about the concept of error. But just as an aside first, I just want to sort of ease that in a little bit by saying that as soon as you use the word error, that can be quite an inflammatory term. And straight away, it's sort of synonymous with failure. Someone's made a mistake, clearly that shouldn't have happened and somebody's to blame and we want to know who. And it can very much bring on a sort of that fight or flight response where people become quite agitated as they either identify with the person who made the mistake and sympathise with understanding the context that caused that mistake to be made, or they identify with the person that suffered as a result of that mistake and they can become quite outraged sort of on that ground. So I really want to take the emotion out of that because as Sir Winston Churchill was fond of saying, those who fail to study history are doomed to repeat it. And the history that we're interested in or the outcome that we want not to repeat is mistakes. And that's key to what I've already talked about, that human element, because human beings do make mistakes, and what we want our system of endeavour to do is to learn to contend with that human fallibility without allowing it to get to the catastrophic or the tragic stage. So we'll have to be quite clinical and set aside the emotive. And if I talk about huge numbers of errors being made within the medical community or within the aviation community, I'm not badging a group of people and labelling them as incompetent. We have to peel back the bandages and really look into that wound if we're going to understand what the damage is and what we need to do with it. So if you'll join me in that, that's what I'd like to try and do. So in some ways this is probably more relevant to this sort of emergency medicine setting than primary health, but as an indicator of how the system of healthcare provision as a human endeavour deals with human factors, I want to look at the concept of preventable medical error. And so there we're talking about things such as misdiagnosis, obviously, administering the wrong drug or the wrong transfusion, injury to patient during surgery, operating on the wrong body part, falls, ulcers due to pressure, and general complications due to failure to follow procedure. All things that in an ideal world, if it weren't for those challenges we talked about, these things could be prevented. And that's an important gauge. In aviation, the ultimate end states that we want to avoid are things like controlled flight into terrain, mid-air collision, between two aircraft, some sort of failure of onboard pressurisation or smoke and fumes that results in incapacitation of the crew. These are the end states that we want to eliminate. They're non-attributive. We're not blaming anybody or saying that they're incompetent, but we're saying those are the things we would like to prevent, because at times they do happen, but if we got our system just right, we could in fact prevent them. So that's the focus. If those preventable medical errors, if we can take them as a performance indicator for how the system of healthcare provision has managed to adapt and overcome the obstacles that it faces, what's the scope of those sorts of errors? The statistics are sort of a bit hard to come by because it's something that's not always captured particularly well, and most of the statistics relate to the United States. But if you'll forgive me referring to American figures, they're probably indicative because we're dealing with a pretty similar sort of social system overall. So there have been a lot of studies done. I think that the real landmark one was in 1999, the American Institute of Medicine to Err is Human estimated that in the United States hospital system there was somewhere between 44 and 98,000 deaths each year due to preventable medical error. But those figures have been progressively upgraded over the years, and in 2013 the Journal of Patient Safety released a study suggesting that the true number was probably actually closer to 400,000 deaths in United States hospitals every year due to preventable medical error. So not people who were sick to start with and were probably going to die anyway if they weren't treated, but those conditions we talked about earlier, those end states that in an ideal world we would be able to capture and avoid. In fact, just this week, the British Medical Journal posted an article online suggesting that preventable medical error is the third leading cause of death in the United States after heart disease and cancer, and accounting for 10% of all deaths each year in the United States. So that's getting to the point now where those losses to heat and friction in a system of well-meaning people that are trying to achieve an end, it's significant. Professor Joe Graydon of the University of North Carolina broadened the context of that a little bit, saying that's in the hospital system. What about in clinical settings, pharmaceutical distributions, aged care? And said the number's probably closer to 500,000 deaths due to preventable medical error every year in the United States. And a Professor Joanne Dish of the University of Minnesota Nursing School, before a 2014 Senate committee hearing in the United States, said we're probably talking not only about 1,000 preventable deaths every day, which is what those figures translate to if you do the maths, but 10,000 cases of serious permanent harm. And she cited the example of a woman in her neighbourhood who underwent a double mastectomy after being diagnosed with breast cancer, only to later find that there'd been a mix-up with the results and that she'd never had any form of cancer at all. At that same Senate committee hearing, Dr. Peter Pronovost, the author of Smart Hospital Safe Patients from the Johns Hopkins University Medical Centre, said, if you think about it, 1,000 preventable deaths every day in our hospital system in America is the equivalent of 2 fully laden 747s crashing every day. We wouldn't accept that, but somehow it all sort of just slips by. Now, again, you know, these figures are, I suppose, a bit overwhelming. I'm not trying to point the finger or be attributive. I'm trying to measure the scope of a problem that interests me because we, as aviators, have had the same problem and have actually been on the same journey. What is it that those 500,000 preventable deaths per year in the United States, and if you look around, figures in other Western countries that are available are quite similar. What do those deaths look like? We all know that it's not slapdash rogue medical practitioners who don't care, clearly. And we talked before about the reality of the challenges that people face. Very well-meaning, very highly trained technically people trying to deliver the best healthcare that they can. To understand where those 500,000 deaths in the United States each year are coming from, I just want to drill down and look at one example. Is anybody familiar with the case of Elaine Bromley in the United Kingdom? Not a well-known case. All right, that's good. Elaine was a 37-year-old mother of two. In 2005, was admitted for elective surgery to her sinuses on the recommendation of her GP. And Elaine didn't survive. On the day that she was admitted at 8:35, she was put under general anaesthetic, and the anaesthetist then set about trying to administer oxygen through a laryngeal mask. He was unable to fit the mask and tried several different sizes, and then proceeded to try to intubate Elaine, but had obscuration from the soft palate and couldn't do that either. Realising that he had a serious problem on his hands, he called on another anaesthetist and an ear, nose and throat surgeon who were in the hospital as well, and the three doctors sort of took turns working feverishly trying to get oxygen to Elaine. At 8:47, 12 minutes after the anaesthetic had been administered, her heart rate and SATs were both down around 40, and as you can imagine, deep cyanosis was setting in. What was the next course of action, do you think? Trachea, yeah. So the senior theatre nurse went and laid hands on a tracheostomy kit and brought in and announced to the three doctors that it was there and ready to use, and this is all very well documented. Some of the doctors looked at her, none of them spoke, and they all just went back to doing what they were doing. And a further 10 minutes passed before they finally managed to intubate, by which time it had been over 20 minutes. And Elaine died 13 days later, having been in a coma ever since. So it's a tragic outcome, but I'm pretty sure every single one of those 500,000 deaths that we talk about looks like that. A bunch of very experienced, very well-meaning professionals dealing with a complication that just was the last thing that they anticipated, doing their level best. But there's two crucial things that come out of this. One was that the doctors collectively were flabbergasted when somebody pointed out to them that 22 minutes had elapsed without the patient having oxygen. They simply couldn't believe it. And that's that human element, because under stress, time compression and a loss of a sense of our situation is very well documented psychologically. But we're all fallible, we're all subject to that, and those doctors lost track of time. And then, of course, the other really crucial aspect of this is that somebody in that team had the critical insight that could have averted tragedy, but for whatever reason was unable to bring that information to the key decision maker in a way that would change the trajectory of what was going on. So that was Elaine Bromley, and out of interest, her husband Martin was an airline pilot. And in the aftermath, and of course sadly, with his two young children being told that his wife hadn't survived, and was told, Martin, we're terribly sorry. It's simply one of those things. He went back some time later and came to terms with that, but he asked, would there be an investigation into the process, and were there lessons that could be learned so that other families wouldn't lose their wife and mother? And was told, well, no, unless there's litigation, we don't investigate. Which to him, as an airline pilot, was sort of quite foreign. Well, surely there must be some lessons that could be learned. So I'd like to talk about another case study now, one that resulted in 8 deaths, and this one's an aviation one that happened in 1978, so sort of a quarter of a century earlier. And I actually remember this, United Airlines Flight 173 on descent into Portland, Oregon in the United States, a DC-8 aircraft. It was 5:10 in the afternoon and en route from Denver, Colorado. A very experienced captain, Melbourne McBroom, with also very experienced first officer and flight engineer, Roger Mendelson. The passengers on board obviously were in good hands, an experienced, well-meaning group of professionals taking care of them. At 5:10, the landing gear was lowered and two unusual things happened. One was that there was a loud thump heard with an accompanying shudder through the airframe. And the second was that one of the 3 green lights that normally illuminate to confirm that the gear's down and locked failed to illuminate. By now, of course, it was dark, and they had about an hour of fuel left on board to consume. So the captain did the right thing and asked air traffic control if they could discontinue their descent at a safe height, go into a holding pattern and try to troubleshoot the problem. The flight engineer went down the back. You can't see the landing gear on a DC-8 from inside because it's under the wings and it's dark, so a fly past of an air traffic control tower is not going to help. But there are some visual indicators, a couple of bolts that protrude above the wing if the gear is down and locked, and they were showing on the relevant side. So indications were that the gear was down and locked. Captain McBroom did the right thing by radio, contacted maintenance engineering at the dispatch base to discuss the situation, and in the end really did his level best not to get into a situation of landing on unknown, unsafe landing gear, which statistically will probably not result in a catastrophic loss of all lives on board, but it's still a situation you would prefer to avoid, a little bit like administering a trachea to somebody who was perfectly well and in for elective surgery. But compared to the alternative, it's what you should do when the time comes. Over the ensuing hour, Captain McBroom became so fixated on trying to troubleshoot the landing gear problem that he was unable to pick up on the growing cues from his first officer, and particularly from the flight engineer, Roger Mendelsohn, that their fuel supply was dwindling and that the landing gear no longer mattered. They were going to run out of fuel and crash into the suburbs of Portland, Oregon. Now, as it turned out, the accident investigation was able to determine that the landing gear had been down and locked all along and that it was a bulb failure that resulted in the lack of the 3rd green light in the cockpit, but eventually, an hour after the landing gear was first lowered, they ran out of fuel and crashed into the suburbs of Portland and miraculously didn't kill anybody on the ground, although they demolished a number of houses, but 8 people on board died, including the flight engineer. Very similar to the story of Elaine Bromley, in that we had a bunch of highly experienced, highly technically trained and capable professionals with the absolute best of intentions, dealing with a stressful situation and a complication that was probably not everyday expectation, and a loss of situational awareness. And in the case of Captain McBroom, he was interviewed in hospital the next day and he was convinced there had been a massive fuel leak. There was simply no way in his mind that the passage of time had been sufficient for that fuel to have been burned under normal circumstances. And of course, the accident investigation team reviewed all of the data, including the fuel flow gauges, and no, he had simply run out of fuel by becoming fixated on a technical problem to the detriment of hearing the advice that was coming from his crew. And that's the other critical similarity to the Elaine Bromley case. Somebody within the team had the critical piece of information that could have averted the disaster that ensued. That case, of course, is sort of 25 years earlier than Elaine Bromley's case. And the aviation profession and airline industries worldwide have done a tremendous amount with that since. And just to look at statistics there, in 2013, over 3 billion people flew on commercial airlines around the world, something like 35 million flights, 210 people died in the course of that. Over the last 10 years, the statistics work out that if you board a commercial airliner, your chance of not safely making it to the other end is approximately 1 in 3.5 million, which means you'd have to fly every day for 10,000 years, statistically, to not make it to the other end. Now, that's not because flying aeroplanes is inherently safe. I apologise if anybody's a nervous flyer, but there are actually an enormous array of hazards out there. I actually had a very interesting conversation with an anaesthetist once, so I flew out to Longreach at 3 in the morning and sat next to me up in the cockpit on the long flight out to get to the patient, where he would then do his work and, of course, travel home in the back with the patient. And after talking for a few hours, he said, you know, what you and I do is remarkably similar. We take people from a place of safety, we dangle them in the jaws of death for several hours, completely unbeknownst to them, and then deliver them to another safe place with them really none the wiser of just how frightening their circumstances have just been. And it's true. I'm sorry, but commercial airline aviation is safe by design, not by nature. And the crucial thing about that design is that particularly that 1978 accident was something of a watershed for our profession to think about the human element and not just the technical training, because it wouldn't have mattered how experienced a pilot Melbourne McBroom was. What mattered was the human breakdown of understanding of the situation and the dynamics of communication between the team. And the airline industry and the aviation profession has done a lot with that since. And that's this concept that we talked about at the beginning of human factors. The first thing that, as a system of human endeavour, we have to recognise is that all human beings will make mistakes. And it doesn't matter if you're at the top of your tree and have been practising your profession for 35 years and are a sought-after speaker on the circuit and looked up to by everybody, you will still get out of bed in the morning and absent-mindedly take your teaspoon of sugar and put it into the rubbish bin rather than the teacup. We are all capable of making mistakes, which when we look back on, we say, I don't know how I did that. All the more so when it's something that we've been working professionally on for our whole lives to perfect. And we're left looking back going, I simply don't know how I could have done that, but that's just part of being human. And that's the first thing that we have to accept. We don't want mistakes to happen, but when they do, that's not a sign of incompetence or criminal behaviour. It's inevitable. We will make mistakes. So what our system of human endeavour has to do is capture that and learn how to learn from the mistakes that have been made to prevent further mistakes from having unthinkable consequences. The mistakes will still be made, but we have to learn how to capture them at the first line of defence rather than being left with an investigation posthumously. And that's something that aviation has gotten very good at doing. The sorts of things that affect the human beings in that system, apart from their inherent fallibility, a whole bunch of factors that actually change our performance significantly. So if we've been out at a big dinner celebrating at the end of a conference the night before, it's harder for us to focus and pay attention. We're more likely to make a mistake. Fatigue, stress, the presence of alcohol or other drugs, all of these things will increase our likelihood of making errors, and they're part of human life, and we're not robots and we can't isolate ourselves from those things. There's then the dynamics of the way that people interrelate, and things such as an authority gradient. Do I feel free to speak up, or am I intimidated by that person I'm working with? Or are we co-equal peers to such an extent that I don't like to say anything because they'll feel I'm talking down to them and telling them how to do their job? Am I comfortable pointing out that, hey, have you overlooked this? Have you considered that? Is there a mistake going on? So to that end, we need to evolve a human system that captures errors and insulates the outcomes from the result of them and prevents recurrence, I suppose, or prevents the consequence of recurrence. A very important thing out of the two case studies we talked about was this fact that somebody on the team knew what was going to happen but wasn't able to bring the key decision maker to see that. Has anybody, as part of their professional development, had any sort of graded assertiveness training? Has anybody heard of graded assertiveness? Yeah, okay. Is it something that is implemented sort of systematically, that you're taught to do, or that...
No, the answer is no. I've certainly worked in the public hospital, and there have been discussions in the public hospital sector about graded assertiveness training.
Okay.
Didn't get much air.
All right, okay. So for the recording, there's been some discussion in the public hospital system about graded assertiveness, but apparently it didn't go particularly far. So the general concept of graded assertiveness is that we have a structure that is embodied, and we're all taught it and we all know it, and we use it to try to prevent the unthinkable from happening. So if Matt and I are flying an aircraft on descent into Melbourne Airport, and as we approach 10,000 feet, the aircraft is still travelling at 280 knots, which is 30 knots faster than it's allowed to be as soon as we pass 10,000 feet. And I, as Matt's slightly junior colleague, but as his first officer, Matt, how's your speed, mate? That's the first step, which is simply probe. Is the person aware of the consideration that they need to see? The second step is alert. Matt, we're at 280 knots. we've got about 30 seconds to get the speed back to 250. Third step is challenge. Matt, we are about to exceed the procedural limit, and we're going to get a report on us for this. Let's sort this out. And the fourth stage is emergency, where you basically say, doctor, you must perform the tracheostomy now, and if you don't, I'm going to contact hospital management because this patient will die. Or in this case, Matt, I'm calling a traffic and asking for extra track miles now. We're about to get ourselves into serious strife here. And there's actually a specific phrase attached to that fourth stage of graded assertiveness that airlines use, and that is, Captain, you must listen. And so important is that process of graded assertiveness that if that phrase is ever uttered by anybody associated with the conduct of a flight during the planning stage, it could be the first officer, it could be a flight attendant, it could be the maintenance engineer on the ground on headset as the aircraft's pushed back. If anybody ever says the words, Captain, you must listen, there's a mandatory report to the heads of that airline straight away. And the reason for that is not because we're catching out a rogue captain who refused to listen or standing up an uppity crew member who was trying to be insubordinate, but because if it got to that point where that level of graded assertiveness had to be used, we need to examine that. There's a lesson that we need to learn because clearly our system of human endeavour has a gap. But if that sort of methodology had been in use in 1978 in airlines, as it is now, or in 2005 in healthcare, then the two tragedies that we talked about probably wouldn't have occurred. There are a couple of things that need to go with that, and I'll just touch on briefly. The bottom line is it's cultural. You can't start trying to push that sort of a change necessarily from the bottom up. It has to be led by the people in charge. And the sort of culture that we need to have is a fair and just culture that protects people who speak up and people who report problems when they see them, as opposed to a blame culture which will tend to suppress reporting and push things underground and prevent lessons from being learned. And we need to have a culture where there's no sort of investigation to hang the guilty party, but we simply say a mistake was made. We prefer that mistakes weren't made, but we know they will be. When they do, that's a data-rich opportunity for us to evolve. That's how we have to view error. Destigmatise it, take the blame out of it, and be ready to do the best that we can do with it. I don't know if anybody's seen the book Black Box Thinking by Matthew Syed. He's a British journalist, but he makes two statements, and I'll read them word for word. A failure to learn from mistakes has been one of the single greatest obstacles to human progress. And secondly, a progressive attitude to failure turns out to be a cornerstone of success for any institution. And that really links back into where we started, which is understanding what we as human beings with our awesome capabilities are also limited by, and how we need to design our systems and evolve them, capture feedback and learn from it to keep getting the outcomes that we want. Ladies and gents, I've actually gone a tiny bit over time, so I better finish there. I really appreciate your attention here this morning, and I suppose I'd just like to finish by saying the sorts of things we're talking about are a journey that certainly Matt and my profession has been on, and I harken back to your mission statement and encourage, if you see any facet of yourselves in any of the stories that I've shared with you here today, I encourage you to be bold and vibrant in looking at that and what can be done with that. And of course, as you can see, we're passionate about this and it's what we do. So if anybody would like to talk to us more about it, then we'd be delighted to carry that conversation on in the break or at lunch or at any time in the future. Do we have time for questions, or do we need to?
No, yet. Anyone got a question?
All right, well,
where could we access this graded assertiveness training that you mentioned?
It's something. The general concept of it is sort of fairly much public domain. But perhaps if you see us afterwards, we can talk more about that. It's not a secret. There are organisations that can help you with it, and we're one of them. Yeah.
Thank you very much, Mark. Certainly, one of the things what you mentioned is really good. I think just to make it really relevant for the primary healthcare nurses here, one of the most important things we can actually learn from the practices or the organisation we work in is what is our method of incident reporting. Who looks at these incidents? How are they reviewed as a team? And then what happens? That the safest hospitals and healthcare settings in the world have lots of incident reporting systems, and just because you have lots of incidents doesn't mean you're unsafe, but what it means is that you learn from all those potential errors, and that's what we actually need in general practice and in many other primary healthcare organisations, a culture where we actually report and have good discussions about how could we have done that differently, better, so that nothing actually would happen.
Perfect, yeah. A reporting culture. Human factors, sort of psychologists, yeah, exactly what you talk about there. Yeah. Well, certainly welcome the opportunity. As you can see, passionate about this stuff and keen to get the message out there and join in the conversations that are going on wherever they are. So, yeah.
It's the blame game that's the problem, though, I think. When you associate mistakes with blame, and the media are the first at its hang the guilty bastard kind of, but that's the problem, sort of if you can divorce it from the blame and make it a learning opportunity, then people will be more constrained to report the things they do and say, put up their hands and say, geez, I landed in Hobart with too much fuel or whatever.
Yeah, absolutely. Did you want to talk? Yeah, leadership is crucial. And it's not something that can sort of be pushed up from below. The message has to be conveyed upwards perhaps, but ultimately it's the people in charge that need to make the decision that they want the outcomes and that they're going to lead a culture change of the sort that you're talking about. And again, that's part of what fascinates us so much with our military background is leadership, human interaction. How do we influence people to get the right outcomes? Yeah. All right, okay, thanks very much, ladies and gentlemen. I really appreciate the opportunity.